Commander Pedley is the Director of the Office of Pharmacy Affairs in the Health Resources and Services Administration. Her office administers the 340B drug pricing program through which outpatient clinics and hospitals purchase approximately $6 billion annually in discounted drugs. Commander Pedley began her career as a pharmacist with the United States Public Health Service in 2000. She was assigned to the Food and Drug Administration Office of Generic Drugs as a project manager for bioequivalence, and then as a medical affairs coordinator reviewing topical drug protocol design. After 5 years, Commander Pedley transferred to the Health Resources and Services Administration and then the Office of the Secretary of Health and Human Services, where she served as the Senior Public Health Analyst for the National Bioterrorism Hospital Preparedness Program.
Really, we want to focus today on where the 340B program has been heading the last year around program integrity and what we've accomplished within that year, which I see as very substantial. Again, intent of the program, very important. Obviously, this program is very beneficial to safety net providers to provide more care to more patients. And we know that this is tremendously beneficial for them. So where are we with our ongoing activities around program integrity? This is really just some of the things that we're doing, but we're really integrating program integrity into everything we do. We've also found over the last year, as we've thought about program integrity, we're doing a lot more around program integrity than we realized, or we didn't call it that. We called it other things, but really it was about ensuring that the people that are in the program should be in the program, and that folks are in compliance with the program. So determination of eligibility, first and foremost. When an entity applies into the 340B program, they have to meet certain standards. And our office looks at every single application to ensure that they meet those standards before they are enlisted and enrolled, listed on our database. Annual recertification. Many of you may be aware, but before the Affordable Care Act, we were recertifying STD/TB clinics and the Ryan White programs, but the Affordable Care Act required us to annually recertify all covered entities. What does recertification mean? I'm going to talk about that a little bit in the upcoming slides and how important that recertification process is for the program and for program integrity, but it's been tremendously successful in sending a message to the entities, I believe, for the first time that they need to be paying attention to compliance. The next year you'll see just some other things. We do quarterly checks of the federally qualified health centers. That's a proactive move on our part that we've been doing for years, where we're able to check grant status. So if someone loses their grant, they're no longer eligible and they have to stop using the program. We're checking DISH percentages on a quarterly basis. We're checking hospital ownership status on a quarterly basis. All that being said, and us being proactive, it's still the covered entity's responsibility to inform us if they are no longer eligible for this program. These are just steps we are in addition taking. The quarterly calculations of the 340B prices and the information we receive from CMS, the maintenance of the Medicaid exclusion file, whereby covered entities determine whether they will be carving in or out for Medicaid to ensure against duplicate discounts. Investigations, resolutions of alleged drug diversion, incorrect pricing, or inappropriate limits on drug access. We look into every allegation we receive, whether that's from Congress, from manufacturers, from entities around compliance in this program. What does that mean? That word investigation, it's not the typical investigation that you hear about, but we work one-on-one with the entity or the manufacturer to work to resolve the issue, to understand really what's occurring so that we can take necessary action. And then, of course, which has always been cornerstone to our work, the technical assistance. We're working to host more and more webinars, posting FAQs and guidances, and I should now be adding regulations on here. So new registration deadlines. How many of you are familiar with the fact that starting October 1, we're going to have new registration deadlines for entities? We had a webinar on this topic, and for those of you not familiar, currently what we do is allow covered entities to enroll the first 2 months of every quarter, and then their start date is still quarterly, but we give them the first 2 months of the quarter to do that. We are moving towards a process on October 1 where they will only be able to enroll the first 2 weeks of each quarter to be eligible again on the quarterly dates. Why did we do this? As you'll hear through my talk, we've begun a lot of work in OPA around program integrity and audits and annual recertification. Guess what? We did not receive any new money or resource to do any of that work. So what we've had to do is reprioritize and shift our thinking around where we needed to be spending our time. This decision was solely resource-based as to why we're only going to allow enrollments to occur during this time to free up staff to work on other program integrity efforts. This also applies to contract pharmacies. We currently do contract pharmacies on a rolling basis. They are not quarterly enrollment. We do them as we receive them. That will no longer be. They will be, only can apply the first 2 weeks, and their start date is now quarterly. And in addition to that, any addition of outpatient facilities, that can also only be done during this first 2-week time period. We're very interested to see how that's going to affect our workload, and it could very well be that we're going to get the same amount, but in the first 2 weeks, but we at least have some time to work through them and then also take on some other work. So this just outlines what the new deadlines will be on October 1, and as I mentioned, there is a Federal Register notice on this. But enrollment will remain on a quarterly basis as it is now. It's just what's affected is the time that they can apply. And these are just some of the details in the FRN about if the 15th falls on a weekend or federal holiday, it's next business day, et cetera, et cetera. The important thing that we're also implementing on the front end is entities have to ensure they have all their documentation to us up front at the time they enroll. What happens now is one registration could take us months because of the back and forth, and the entity just wants to get their application in, and they'll get us the supporting documents later in the process. Well, we're no longer going to allow that. They need to do it up front, but that's also requiring us to be very clear on the front end what it means and what documentation you need on the front end. So we are in the process of revising our form so that it's very clear up front everything you need before you start the online process. That gets in really to this point as well about making sure that they have all their information. Again, covered entities are responsible for immediately notifying OPA of any changes to eligibility. Even if they wait 2 months to tell us, if they lost eligibility 2 months ago, they're receiving letters from us stating at the time you lost your eligibility, you have to repay if you made 340B purchases after that date. We are working on a mechanism to make that information available, especially to the manufacturers as they are involved in that process, on how that will work. Contract pharmacies, again, as I mentioned, this really changes how they will be enrolling into the program. The biggest point we're finding in the contract pharmacy area is bullet 3. It's very important that a covered entity does not submit their contract pharmacy registration form until they have a signed contract in place. The other thing we are implementing as we take the contract pharmacy registrations online, so right now a pharmacy itself can submit the forms to OPA and we put them online. There's now going to be a process by which whoever can submit the registration form, but an automatic email will go to the authorizing official that says, do you know this person submitted a contract pharmacy for your entity, so that the entity is aware and knows about this contract before we list them on our website. So again, those are some things that we're doing on the front end to improve integrity. Again, already mentioned these items. We went online with our change request process, except for the few things you see here. Again, we're moving towards making our systems more efficient and online to free up staff time. Again, we're moving towards contract pharmacies going that way as well. You'll see the last point here, and there's been a lot of discussion about terminations in the 340B program. As many of you may be aware, this process is currently done quarterly, but there's a tab in our database that says when the actual change was made, and manufacturers, rightfully so, have been asking, well, what does it mean for us if I know an entity is no longer eligible at a point in time, but your database says it's not effective until the next quarter? We've been working on this issue very closely with CMS, and we are moving towards an approach where we may be making terminations immediate in the database versus quarterly. Now, of course, that brings some complexities for you all because we need to find a way to inform you of the immediate terminations so that you don't have to go into our database every day to see who's terminated. So we are working on some processes. For an example, we believe we may be doing something like a push notification or an email subscription that you will sign up for to get the list of sites that are terminated on a weekly basis, for example. So it's something we are still working through. We know it's an issue for you all. But we're aware of it, and we're trying to find some solutions around ensuring that the database reflects the actual date that someone is no longer eligible for the program and should not be purchasing. But regardless of the date issue and what's listed, it's still the entity is not eligible to purchase after they're no longer eligible, and if they do, they have to repay. Some database improvements, although you might call these database headaches that you have found over time. And I want you all to know that a lot of the changes that we've been making in the database and the requirements we are making for covered entities, the purpose of making these changes is for more transparency into the system. You may be aware that in the past, we have not required outpatient facilities of hospitals to list their clinics on our database. Well, we have now moved towards an approach where they must list all sites where they are using 340B drugs for their patients. This has created some headaches in the marketplace around creating new accounts where the drugs are shipped and billed, and we had pharmacies that were listed as outpatient clinics that really should have been shipped to addresses, not outpatient facilities. So we've worked to provide more clarity to the entities on what it means to be listed as an outpatient facility. We do a very high-level review of who can be an outpatient facility, and our test is that they have to be listed on the most recently filed cost report in order to be listed. So I want you all to work with us on this. We know it's caused some headaches around new IDs being created and having to work with the wholesalers around this as well, but it's very important. We want a database that captures every site that's truly participating and using 340B drugs for its patients, especially in our new world of HRSA doing audits and manufacturers doing audits, so you know exactly whether that site is able to be using drugs at that facility. So that's why we're moving more towards transparency in our database. I can tell you that this hasn't happened overnight. A lot of the entities are working with us to make sure all their sites are listed, but there are some that have 100, for example, and we're working with them to make sure that they get them all listed, but again, it's not going to happen overnight. The other clarifying point I want to make, we've only made this move for outpatient facilities off-site, the main covered entity. So if they're within the four walls, they do not have to list every department, clinic, emergency department within the four walls. It's only those sites that are off-site, the parent hospital. A little bit about recertification. As I mentioned, separate from recertification, we do these proactive quarterly checks on eligibility status as a way to catch anything that really slips through. But on annual recertification, as I mentioned, in fiscal 12, we completed the Ryan White STD-TBs, the family planning, the hospitals, and we're looking to start the FQHCs. We already started communication with them, but the actual online process won't start for them until January. And we're going to continue with the other entities as the online systems are developed. This is a cost for us, so we're only able to do the entities as we have the funding to put everything online. So why do we do annual recertification, and what is it all about? As I mentioned, it is required now by the statute for us to do annual recertification of entities. And the purpose of it is to ensure integrity, compliance, transparency, and accountability. We first and foremost want to make sure that all the information in the database for an entity is accurate and up to date. Granted, entities should be updating this upon any change they have, but they then have this annual recertification time to ensure that it's accurate. And it's also, again, their responsibility. I'm not going to go through the next few slides. They're very detailed in the slides that we use for different entity types as we explain recertification. This goes through the steps. The reason I wanted to show them to you today is that we have a very robust process in place for recertification. We do learn from it each time, and we learned a lot from the hospital recertification, as you can imagine, because it has a whole other level of complexity with it because they're not a grant organization. But these are the steps that an entity has to go through. And I will say, again, that it has been very successful. The next two slides, you can see they're very busy, but I wanted to put on here word for word. For the first time with the hospital recertification process, in addition to ensuring their information is up to date on our database, they have to attest to these compliance requirements. We believe that these compliance requirements are within the statute and that they need to understand what their compliance requirements are to participate in this program. I believe that for far too long, we've been silent about an entity's responsibility around compliance, so we are moving forward and being more transparent about what it means for them to do this. We're also adding these to our new enrollment forms. So before anyone even enrolls into this program, it can no longer be about someone just signing up because they know they can get cheap drugs. They need to upfront understand, okay, I want to do that and have a benefit for my site, but what does it cost me to be compliant? How much am I going to save on average? Let me do a cost benefit to see, to run a compliant program, I'm still going to save this much, so yes, it's worth it for me to participate. I think that what has happened over the years is a particular hospital or site will see, oh, I'm listed in the law, I'm eligible, I should just do it because I'm listed. I can tell you from what we see, it's not for everyone. The program doesn't benefit everyone. Whether that's because they don't have a robust system in place, they don't have the staff to ensure compliance, it's not for them, or because they're not going to save enough money on the program. So it's important that they understand what that means up front, and then they join. And you'll hear from Lisa and Chris about the efforts we're taking to educate on the front end what it means to be compliant, and then you join the program. So these are those 8 attestation requirements. Success story, I believe, hospital recertification. Here are our outcomes, very high level, of course, of hospital recertification. There were 267 sites that were decertified through the process of recertification for various reasons that we are still in the process of working through with each and every hospital. But here's some examples. Some hospitals went for profit, and they were still listed on our database. We're in the process of asking each and every one of those hospitals, when did you go for profit? And if you purchased when you went, after you went for profit, you have to repay. And then we will make that information publicly available. Remember, with hospital recertification, there are hospitals that have been in our system since the very beginning of this program, so we're now talking 20 years. So another reason is that the hospital just doesn't exist anymore. They were on the database and just never taken out because we've never done this type of process before. There were also some where their dish fell below. And again, we are working closely with them now to understand when their dish fell below and their most recently filed cost report. And again, if they purchased at a time when they were no longer eligible, their requirement to repay. Very important, and again, we will be making this information available to everyone, but we're still working through the process of how we're going to make that information available versus posting 267 letters on our website and saying, go look at all of them and see if you need to go take action. We don't want that to happen. We want to work with you on creating a process that works. But to me, hospital recertification was a success. Some other things that came up, there were some self-disclosures that came through the process of, now that I read through these, we might be doing this, or that wrong. We wanted to tell you about it. We're going to do some further research. We'll let you know what we find. We're seeing a lot of that as well, I believe, for the first time, and the importance of an entity to understand what it means to inform OPA of compliance issues that they find. Policy releases. We started these last fall as a way to get out information to the public about clarifying issues that were coming about, and a lot of these, as you know too, were in response to the GAO study that asked for us to re-clarify a lot of our policies in these areas. So all of these are listed on our new program integrity page on our website, which is another effort that we've done to focus all the program integrity efforts on one site on our webpage. You'll see the last two here, the Medicaid exclusion file policy release, which we're pretty close on, to help entities understand what it means to keep it up to date, what it means for states to tell us if they have issues with it. If you remember an OIG report that stated that the states weren't using the file because they found a lot of inaccuracies in that database. Well, we've opened our arms to the states. We had a webinar for them. We've created an email address to inform us of the issues they were having so we can fix it, but we're not hearing from them. So we need to hear from you if you're having issues with the exclusion file. It is the source of truth and the first step that needs to be taken to understand carving in and carving out. We want to work with the states on this effort so that we can clearly improve the file. We're also working very closely with CMS on the Medicaid exclusion file policy release. And then the last, the GAO report asked us to clarify some issues around hospital eligibility, which we are also in the process of doing. So more generally speaking, our program integrity strategy is focused on now moving towards audit for the first time ever in this program. The A133 process, how many of you are familiar with what A133 is? Okay, not many. The A133 audit is an audit that has to be conducted by grantees that receive more than $500,000 from the federal government. They are required to conduct an annual audit. An independent auditor has to do this audit for them on an annual basis to report back on how they're using government funds. For the first time ever, starting in fiscal year 13, we have incorporated into the compliance requirements for the A133 process for the grantees 340B compliance questions and items that they will look at and sample. The purpose of the A133 audit is not as in-depth as our on-site audits, but they're going to serve as a way to trigger to us problems that we then need to go in and look at. We're still in the process of trying to define the N of how many we think of the 340B entities will actually have an A133 audit. Obviously, the hospitals will not be included in that, but we believe that most of the federally qualified health centers will be included in that, and possibly many of the Ryan White programs as well. So it allows us to cover more of an area because we can't obviously do 18,000 on-site program audits. And our program integrity strategy does focus on these three areas: eligibility, including the GPO prohibition, diversion, and duplicate discounts. And again, we follow up on every allegation that we receive. So where are we with our audits? Again, all covered entities are considered for the random audit selection. They're conducted by HRSA regional staff that are in the field, and then they work with us as they conduct those audits, and then they supply their preliminary reports to our office, who makes all the final decisions. You can see some areas here with the audit focus areas, and we do have a one-pager on our website that outlines not the actual protocol that's used on site, but what the expectations are. So it really does outline what's covered in the audit for the most part. And the other point is that we also have the authority to conduct audits of manufacturers. As many of you know, from the very start, we've had the authority to audit both covered entities and manufacturers. We also need to ensure that on the manufacturer side, that there is compliance, that they're not overcharging, and that they are supplying drugs at the 340B price. We are in the process of looking into some issues with manufacturers, so just understand that we also do have the authority to audit manufacturers. So where are we today? These started in fiscal year 12. We developed our audit protocol last fall. We tested it. We improved upon it. We randomly selected 45 sites for random audits, and then we chose 6 to target audit. Obviously, the random audits are chosen both based on a risk stratification, so it's not purely random, but we factor in, for example, volume of purchases, the complexity of their relationships. For example, if they have 100 contract pharmacies, that would put them at higher risk on our random stratification, et cetera. And on the target side, those are when we receive specific allegations that then would, that need us to then go look on site to actually see what's happening. All of the on-site portion of all of the 51 audits are complete at this time. So we have completed the 45 plus 6, the on-site portion of the audit. The results are preliminary until finalized by the Office of Pharmacy Affairs. And the goal then is, after we can take a look at what we've learned from the 51, we will create tools and resources to help the rest of the 340B community to be in compliance with the program. As you can imagine, absent regulations in this program, it is very difficult for us right now to quickly work through the audits. Are we finding issues? Of course we are. But we have to ensure that what we say about them and then the penalties applied to them are supportable currently by statute, absent the regulations that we need to eventually put in place, and we do plan to put in place in the long run. But I think that until we get through this first group, which is going to take us a while, as you can imagine, for the first time ever, we'll be in a better position, but it is taking us a while, and we appreciate your cooperation and understanding of why it is taking us so long the first time around. And honestly, the last few audits just completed in August, so it really hasn't been that long since the on-site portions of the audits took place. We receive the reports. There's back and forth then with us and the auditor to clarify and issues that we don't understand within the reports. There's times where we have to go back and forth with the entity 3 or 4 times to really understand what's happening on the ground, through letters, through phone calls. So it's a very cumbersome process, a lot of back and forth, a lot of working with the auditors and with the entities to truly understand, okay, this is what happened and this is what we're going to do about it. So now let's talk about the audits that the manufacturers are conducting. Manufacturers also have the authority to audit covered entities, and until the recent, have never done so. The manufacturers do have to establish reasonable cause and have an independent auditor do this work. They have to submit that plan to OPA prior to conducting the audit, and that's outlined in a Federal Register notice that you'll see cited there. We want to work with manufacturers on this, and we have worked with manufacturers that have moved forward in this process. We've received 3 audit work plans, and again, I think once a few of the manufacturers are able to conduct audits, that you also create a forum to share with each other what you learned about, what did you need to establish for reasonable cause? What was it like to work with OPA, which I hope was a good process. We are, just so you know, because this is new for all of us, we've worked very closely with the manufacturers pursuing audits on the front end. We've reviewed templates with them, gave them some feedback before they've submitted their final to us so that we could work through and talk through the issues together. We only have, once they submit their final audit work plan, we only have 15 days to review and respond to them with any issues, and we've met all of those deadlines. But we want to work with manufacturers on this. We think it's also important that manufacturers move forward on conducting audits where they find issues. So again, we see some progress in this area, and we are glad to work with manufacturers through the process because it's new for all of us. I already talked about the A133 audits that, again, those questions are in place starting fiscal 13. And then I wanted to stop and take a breath and talk a little bit about really everything I've talked about in the slides so far and how far I've seen us come in a very small amount of time around program integrity and the importance of really reflecting. First ever audits conducted in the 340B program this year, and we've completed the on-site at 51. First ever 340B audits by manufacturers, and what are we going to have to gain and learn from those? The inclusion of 340B into the A133 process, the first ever annual recertification of hospitals, providing more clarity on enrollment, updating our enrollment forms, which is currently going through OMB clearance to really say up front what the requirements are to participate in this program. More transparency of the 340B 340B database, and there's more to come on that. We want to make sure that it's not a black hole to understand how these sites are using 340B drugs. It should be very clear where they're using them, and they went through a process, and OPA approved that it was okay for them to use them there. The policy releases, we've had a lot of webinars with manufacturers, with grantees, with the hospitals about many of the processes we've put in place. So I feel we've come a long way. We obviously, though, we want to do more. And as I mentioned earlier, we've done all of this with no new money or resource. And here's where I start to talk about the fact that we need a user fee in this program if we want to take it to the level it should be at. And if we want to get 18,000 entities into compliance and be doing a much more representative sample of audits than 51 out of 18,000, we're going to need the resources to get us there. And that's why the president in his budget has proposed the user fee for this program. So some resources, and you're going to hear from Lisa and Chris about the resources that are available. Obviously, we have a contract with the American Pharmacists Association specifically around the 340B peer-to-peer learning network and to talk about the operational issues that entities are having. And again, the free technical assistance to many of the grantees, but not all of them, because this is an area we had to cut due to funding. As you know, now the manufacturers are not able to get that assistance from PSSC, the information analysis and relationships and networking. And of course, the 340B Prime Vendor Program, which you're going to hear about from Chris in our contract with APEXUS, and the information on their website and their call center, the 340B University, which I hope many of you have heard about, maybe some of you have even attended, and our goal to ramp up again, education to ensure that entities understand on the front end what it means to participate. But also, because so many already are, we want to get them quickly up to speed and into compliance as well. So I'll reserve for them to really talk about their programs, but they both provide tremendous value to our office to be able to service that many covered entities, manufacturers, Congress, to really work through problems we're having in the program. And last but not least, I don't often get an opportunity to talk about some of the other work that OPA does around the Patient Safety Pharmacy Collaborative and the focus on safety. We believe it's very important that entities, hospitals, healthcare delivery sites understand it's not just about providing the medication or providing medications. It's about doing it in a safe medication use system because we know the harm that medications can cause if they're not in a safe med use system. So in partnership with CMS and their Quality Improvement Organization program, we are going into our 5th year of the collaborative to really integrate across the country safe med use practices to ensure that they are learning from each other about what that means to improve safety and health outcomes for the patients that they serve. There's over 200 teams that participate in 48 states across the country. It's been tremendously successful. We've received a lot of awards for it. I encourage you to go to our website to learn more about this Safe Med Use initiative. So with that, here's our contact information, and I'll go ahead and turn this over to Lisa and then Chris, and then we'll take questions.